So kind of getting into what our brief goal is in terms of the information that we're going to talk about is kind of evidence-based bronchiolitis guidelines. We're going to talk a little bit about different parameters that we use locally for high flow nasal cannula. Welcome discussion from the rest of you in terms of kind of what you're doing locally in contrast with what we're doing, as well as, again, as we go along, if there's questions that arise or points of discussion, please feel free to interject or put things in the chat so that we can discuss that more. And then we'll talk about some of our latest and greatest. We'll see how much of an impact they have this year, but our RSV prevention strategies. Bronchiolitis is caused lower respiratory tract infections. We technically define it as kids than less than 2 years of age, although all of us have probably seen kids who are past that threshold. We tend to call that viral pneumonia, but there's certainly a spectrum of disease, but this is the technical definition. It's typically characterized by having inflammation and edema of the airways. A lot of these kids, as you can kind of see in this picture, the response to these viruses is just having tons of mucus and inflammation in their small airways, which causes often respiratory distress. We spend a lot of energy in this, and I think that's also why there's been more efforts on the prevention. It's the number one reason for admission for children less than a year of age. And it's also can be a fairly protracted illness lasting up to 12 days.
I feel like that's when I spend a lot of time talking to families about is sort of just anticipating that this one is going to last longer than the average upper or lower respiratory infection. And Heather sort of alluded to this. We often use bronchiolitis and RSV sort of synonymously, and certainly RSV causes the majority of bronchiolitis, and especially during these seasonal times, it causes these seasonal peaks. But again, I think many of us have seen bronchiolitis caused by many of these other viruses as well. Rhinovirus is one that I feel like is sort of a gift that keeps on giving, because I feel like year-round we see kids with bronchiolitis who are presenting because of rhinovirus. COVID, although I will say anecdotally this year it feels like a little bit less than maybe we have seen in some previous years, but certainly can cause it as well. Influenza, I think I jinxed myself because I was saying recently that I hadn't seen an influenza bronchiolitis recently and had one in the emergency department on my last shift. And then human metapneumovirus, some of the non-novel coronaviruses and paraflu can do it too. And then also important to remember is that we can get co-infections with multiple viruses at one time. Just this past week, we had a 4-month-old who had 3 different, I think she was RSV, COVID, and paraflu positive. And so we certainly, I feel like anecdotally, again, sort of see increased severity as we see viruses kind of stacked on top of each other. And it also can cause the timeline to be a little bit trickier and less classic than we would see with just the single viruses. We are, I will say, seeing a lot of RSV, a fair amount of rhinovirus still. And then while we're seeing flu, again, I'm not seeing a ton of flu bronchiolitis, at least. Does that match with what you all are seeing as well?
Yeah, I think that's why I made that mental slip earlier. I would say I'm on service right now, and almost every patient that I have with respiratory symptoms is positive for RSV. As you mentioned, like I have some that are positive for other things, but are coming in more for dehydration or other complications as opposed to respiratory distress.
We know that RSV and bronchiolitis can affect kids in general. Again, that definition is under 2. We tend to see the most severe disease, so children needing hospitalization, including ICU admission and respiratory support with these risk factors. So infants who are born premature, the younger you are when you hit bronchiolitis season and get infected makes you an increased risk, as well as having any underlying pulmonary disorders, neuromuscular disorders, or congenital heart disease. There is data that shows that infants who are exposed to tobacco smoke have both increased risk of contracting bronchiolitis as well as risk of severe disease if they get it. And interestingly, maternal asthma is another risk factor for having severe bronchiolitis as well. And as we think about those high-risk categories, it's kind of a nice segue into the prevention efforts that have been active over the last couple of years. And again, sort of exciting as we hope to see them make a difference and maybe, sort of tamp down some of the numbers that we're used to seeing during these winter months. The big player out there right now is this nirsevimab or Beyfortus, which is the monoclonal antibody immunization that is given. All infants are eligible for it if they are going to be less than 8 months when they hit bronchiolitis season. And then kids who are a little bit older, so in that second year, are in that first to second year are eligible for it if they have risk factors for severe disease. It's nice is that it's given as a single intramuscular dose with the dosing based both on age and on weight. And it can be given at birth before the infants leave the hospital if the timing is appropriate in relation to the RSV season.
I was curious if anybody else can chime in terms of if you know kind of what the access has been like in your community. For us, we in the inpatient setting are trying to capture all the patients who are high risk. At different points, we haven't had the supply be ample enough to give it to every single patient, but we've always at least given it to our patients who are high risk. And if for the patients, if we haven't been able to actually give it and they're eligible, also just made sure they had follow-up and really encourage them to get it. But I was curious what other people are seeing in their communities.
This is Ramin Ashraf from Antioch, Sutter Delta. We have the Sutter wide, whenever you order the vaccine, there's a questionnaire about, one of them is if the patient is not able to get it in a timely fashion after discharge, or if the patient is in the NICU, things like that. But my experience is that a lot of mothers, most of the mothers have been getting the vaccine antenatally. So that's been really helpful.
That's great. Donna, were you going to let us know what?
Yeah, at our hospital, so this is new to us in Canada too. We just rolled it out. So we've actually kind of missed the babies before our RSV season started. We didn't have access to nirsevimab up here. But by the time probably late October, early November, we did get our stock in. We've been good for supplies for our patient population so far. We're giving it at birth with a vitamin K injection as long as we have consent from parents. We have probably about a 70 to 80% uptake, but what we're seeing are all those kids that were missed earlier in the year are the ones coming in and presenting to the hospital and needing supportive care as they work their way through RSV and whatever potpourri of virus and illness comes with it.
So
this is Jenny from.
Oh, go ahead, Jenny.
I was just saying, here at Enloe, we just started giving the vaccine at the hospital to the newborns, the high risk newborns, in December, but they have been getting it in our community from some docs for the last year.
And what it sounds like I'm hearing is that families have been pretty receptive to it from what people's experiences have been.
They have been up here for sure.
Yeah, it's strange. There is a lot of vaccine hesitancy in our community, but it seems there's this weird different thing with RSV where people just kind of seem to know RSV and it seems to be treated by parents a bit differently. And I don't know exactly why that is. I can only assume that it's just so rampant in the population during the winter months that people have had a lot of exposure to it. So when you say RSV and something for prevention, then we're having a lot more yeses than nos, which is really nice.
That's fantastic. I like the idea of giving it with vitamin K too, because I feel like that's, just such a routine part of newborn care that if we can sort of get them all wrapped together, maybe we can also get uptake increased there too.
Hi, this is Aunt Rosemary. So at community medical centers here in Lodi, I'm giving it, we have very easily accessibility to the nirsevimab. I've been giving it to every baby that's been coming in literally for their first newborn examination. So they're 3 days old and they're getting it. And yes, parents are much more actually, those parents that are vaccine hesitant, yes, are giving the RSV easier than a vitamin K injection or a hepatitis B vaccine, simply because I think it's more known to them and how serious it can be. Also, being a pediatric hospitalist, I have shared some personal traumatizing experiences, especially with triple infection of infection. I had this one 3-month-old that went into a cold white for me. She was RSV, adenovirus, and metapneumovirus all together. And so it's the risk is, I tell them my personal experience and they're more happy. Of this, I've had several babies that had received the vaccine in October, November, have now been sick with RSV. They have gone to the ER, but have been very stable and no hospitalizations. So of all the babies that have been vaccinated since October, not one of them have been yet hospitalized. A few of them have gone to the ER. but have been on basically just supportive care at home. So it's good news.
That's great. The numbers look, from what I've seen, it looks like sort of 70 to 80% efficacy in terms of preventing hospitalization. So while it's not perfect, it sounds like your record is perfect, but overall it's good, but not perfect for the vaccine as a whole.
We'd alluded to this a little bit earlier in terms of also having uptake of the vaccine for people who are pregnant. It should be offered between 32 to 36 weeks of pregnancy. And then ideally, it should be administered at least 2 weeks before delivery in order to protect the infants that are born to those parents. And then if they've met that criteria, then they shouldn't need the additional Beyfortus for protection. And then I was talking to Leah a little bit about this, but I haven't had any clinical interaction in terms of the adults 60 years and older, but they're also being offered RSV vaccine as well in order to provide protection. I think like if we had to just give one slide, this is maybe the one that I would choose of the basics of bronchiolitis. I think the most critical thing is nasal suctioning. I think for a lot of patients who present with respiratory distress, just getting their nasal passages clear can make the biggest difference. And I think along with that is figuring out methods for the families to be able to do that at home and effectively do nasal hygiene. For those patients that need it, administering oxygen, I would say, especially here being closer to sea level, we have a lot less hypoxia, but certainly see that and see a lot more respiratory distress. And then finally, providing hydration or nutritional support. Usually if we can address kind of the first two things, oftentimes these kids will feed through their illness, even if they're relatively sick, but just making sure that we're addressing that. And in those cases where the patient has such severe illness or respiratory distress, being able to provide that. And then I saw a question pop up in the chat in terms of the cost for the immunization. I don't know that. I don't know if there's anybody else on the call who has more awareness in terms of the cost. I do know, like, at least in our health system and the insurance that's provided through our employer, that it's covered, but does anybody else have any other insight? So maybe that's something we can work on finding out that information and sharing it with the group afterwards.
We had wanted to talk about evidence-based guidelines for all of our talks, but specifically for bronchiolitis. It's a little bit ironic because the guidelines for bronchiolitis actually haven't changed since 2014. I anticipate, given these new prevention modalities that we've been talking about, that they'll be adding those in and we'll be getting some updated ones soon. But interestingly, basically in terms of the evaluation of bronchiolitis, it really hasn't changed over years. Basically, the recommendations remain that we should be diagnosing it just by our history and physical exam. So we don't specifically need labs. We don't specifically need x-rays to make the diagnosis. I will say that in our practice, mine personally, and I feel like here at UC Davis, at least in our emergency department, since the COVID pandemic, we have definitely sort of defaulted to much more point of care viral testing than we did before. I think that sort of in the past, we would say, it doesn't change our management if we know which virus it is or it isn't. It's supportive care. And we would offer that to families and sort of give that reason. And it worked pretty well. And I think just in sort of the shift that's happened with people expecting viral results and us wanting to test for COVID and during flu season testing for influenza also, we have been much more routinely testing for RSV and RED. We routinely do it under 6 months and then often do it sort of up to 2 years. And then in our kids with underlying or chronic conditions, we'll do it even older than that. And I, at least as I'm training, I try to remind our trainees that, this isn't recommended, it's not evidence-based, but it's sort of what has become the expectation of our patients and our families over these last years. And then chest x-ray is a question that often comes up because the lung exam on some of these kids can be so impressive. I think that often we want to, get a look and just make sure that there's not a bacterial source, or maybe the timing of the illness is not classic. And so we're wondering about a bacterial cause. The recommendations remind us that routine chest x-ray is not recommended. That's not to say that, we can't get it in any of the kids. And the sort of subsets that are more obvious who might benefit from chest x-ray are kids with more severe disease. So ICU admission is sort of a surrogate marker for that, but kids who maybe aren't responding to our management modalities the way we would expect them to. If we have specific concerns about an airway complication or a pneumonia, based on their time course or their clinical findings, or persistent asymmetry on lung exam. So we certainly can hear some asymmetry with mucus plugging in bronchiolitis, but it tends to sort of shift around and be one of those dynamic exams that is frustrating if you're trying to teach someone about bronchiolitis, but also can be reassuring if you're not hearing abnormalities that are persisting in one area. So if they do persist, then that's a group of kids that we also want to maybe look a little bit closer and consider an X-ray. One of the questions that that comes up a lot in this age group in kids with bronchiolitis is how much we need to look for other sources of their fever when they come in febrile with their bronchiolitis. The guidelines released by the AAP for infants under 60 days of age actually specifically mention clinical bronchiolitis as a reason not to use their guidelines. So it sort of kicks them off of the guideline and you just have to use your own clinical judgment for them. I've looked at different studies that have shown different things. There's a recent study that just came out that showed that there's still a significant risk of serious bacterial infection in young infants, so under 1 month, who have RSV positive. And when you split that one out, it seems like having clinical bronchiolitis is a different risk than just having a positive viral test, but there definitely is still potentially a risk. So I think, again, it's a matter of using your judgment. I routinely still evaluate for urinary tract infection, knowing that co-infection is present at a rate that is about half of what it normally is without bronchiolitis, but still measurable. But I don't necessarily routinely screen for bacteremia or meningitis. But again, depending on the age of the child and the timing and the height of the fever, I can certainly be convinced to do that.
Do you mind, Leah, talking a little bit about like what approach you take? Just meaning like for a lot of families, if we want to do the gold standard of cathing, they can be concerned about that. So how do you approach it in the ER and in a kid who's early in their illness?
For our urine screening, we'll actually start with a bag urine sample for many of our infants. A negative bag sample UA is been shown to be sensitive enough that we can believe that and we can avoid cath specimens if we need to. The positive urine bag will send us back to talk to the family about doing a catheterization. And sometimes we even warn them that this is the first step. And if it shows anything, then we would need to do a catheterized sample. And then in terms of explaining blood work, and I often do it in sort of a stepwise way, it seems like urine is an easy one to discuss. Blood work isn't too hard to discuss. And then we'll sometimes leave the LP discussion or CSF discussion for a little bit later as we see how things look. But this is another place where some of those decision rules in terms of looking at inflammatory markers in these young infants and looking at sort of their clinical symptoms and their viral results will sort of push me to emphasize things differently in my shared decision-making discussions with the families.
So this summarizes all the things that we're not generally supposed to do. I think just kind of highlighting some of them. I think for bronchodilators, obviously in the inpatient setting, I have the luxury of time. And so I would say it's not frequent that we use bronchodilators, but I think for us, what we try to emphasize is doing a pre and post assessment and trying to objectively evaluate if there's any improvement with the bronchodilator, but don't routinely use them. It's pretty rare in terms of using steroids. I would say the population that we sometimes use that in is our patients who have a history of prematurity and chronic lung disease, so some complicating factor. But for our routine bronchiolitics, it's pretty rare that we use steroids. Don't often use antibiotics, although sometimes it's difficult to discern for kids who have had x-rays or have a more prolonged course. What patients may or may not have a community-acquired pneumonia, but a lot of these patients also have atelectasis, which sometimes can be difficult to distinguish. I can't think of the last patient I ordered CPT on. So that's something that really is extremely low frequency that we would use, except in a patient who has some other comorbid condition. And then hypertonic saline has been interesting. I feel like some people like it more than others. The evidence in terms of that for an inpatient setting is, at least in the most recent stuff, equivocal. Some things show benefit, some things show not a lot of difference. So we don't use it frequently, but we do occasionally use it in the inpatient setting. But the official recommendation is not to use it in the ER.
I think it's interesting when our guidelines tell us all the things not to do. There have been some groups that have looked at what is actually being done. And these data are from some administrative databases looking at children with bronchiolitis under the age of 2. And it looks like they are still getting some of these treatments and evaluation techniques that are not recommended. So steroids in a minority of patients, but about 15%, albuterol, at least as trials and potentially longer for 60%, antibiotics in 30%. And I do suspect that some of that is from those chest x-ray findings that are sort of equivocal. And sometimes that's my reason for not wanting to get a chest x-ray, is not wanting to sort of open that can of worms when things look so viral. And then chest x-ray in 50% in these national numbers. We looked recently, just a quick look at our data from RED, and our chest x-ray numbers were in like the 20% range for our kids with bronchiolitis, at least in kids who had viral testing and or a diagnosis of bronchiolitis and had in that age group who had chest x-rays done. So it's not zero, but it's hopefully getting lower with time.
This is the respiratory assessment classification that we used. We use this by reviewing other resources and institutions' guidelines, and then had a working group who worked through this. And I think what's hopefully most useful for this group is just looking through the 3 primary things that we look at are their respiratory rate based on age, and then classifying that as mild, moderate, or severe, their work of breathing, and then their mental status. And it was interesting. We had a group that included like PICU doctors, nursing, and people who cared for patients in lots of different settings. And some of the discussion, I think, particularly on the mental status and how we assess that, which can be really different from a patient who's 4 months of age versus a kid who's 19 months of age. And so I think this gives just people a framework in order to evaluate patients. And I was curious if locally you all have any sort of particular assessment that you guys do in terms of having any like common language in terms of where a patient falls. While people are thinking about that, I'll also just add, for us, we classify them as whatever their highest score is. So if they are moderate for work of breathing and mental status, but their respiratory rate is in the severe category, then we would call them severe. Jenny, were you going to chime in?
Yeah, so we use the pediatric respiratory score at Enloe, and we do use that like as when we're trialing our bronchodilators pre and post. So it actually gives a number, but similar things that we're assessing in that scoring system.
That's great. I feel like that's one of the really useful ways to use it, is having that way, as at least as objective as we can get when we're considering I think both bronchodilator trials, and then for us, the sort of communication between teams, so that we're all sort of speaking the same language. It's really simplified how we describe patients when we're talking to an admitting team or to our respiratory therapists to kind of all be on the same page. We have a video that we can show of a child who presented to our emergency department. This was a 16-month-old little girl who had come in. She actually had multiple episodes of viral associated wheezing. This was the second episode that she came in with, which is part of the reason I'm also explaining, because she does have a neb mask on, and we were doing a trial of albuterol in her because she had wheezed previously to see if it would help. But I think it gives us a chance to kind of look at some of those findings that we talk about in that respiratory assessment classification and kind of see how those look.
Is there anybody who's willing to chime in and just see, speak to what you're noticing or?
This is Jenny again. So things I'm noticing obviously are retractions. I see subcostal, intercostal, external. I also, most noticeably, I feel like that the patient itself really kind of just seems to be staring off and seems really tired.
Mhm.
I didn't count the respiratory rate, but it seems fast for that age.
Yeah, that's exactly the things that we were noticing too. I did count her, and she was between 68 and 72 during this time, and that was pretty much what she had been doing. And then I agree, sort of all those retractions that you were seeing, and right, it's sort of nice that she was so calm with that, especially giving that neb treatment until you think about how a 16-month-old would normally be with that. And you're exactly right that that sort of staring off does suggest some fatigue, which is like likely respiratory fatigue in this kiddo. So there's a QR code in the corner here that will take you to the UC Davis pediatric guidelines. If it's helpful to you to see what our bronchiolitis guidelines, they are included on there. Basically, the first steps of our guidelines are just to do the things that we've talked about. So examining the patient, suctioning, and then we try to assign their respiratory classification after suctioning, kind of trying to catch them in that ideal state where they've sort of settled down after we've gotten them all riled up with the suctioning and kind of see where they settle, giving that supplemental oxygen if they need it. And then for kids whose work of breathing is moderate or severe, that's the group that we are considering our high flow nasal cannula in. Heather talked a little bit about rehydration, which we can often do PO if we can get their respiratory status stabilized. And I will say most often we're still doing IV placement in the kids who aren't able to take adequate PO. We know that NG is an option, and we've sort of talked about some different efforts to improve and increase the use of that, but that's still sort of a work in progress, and so we're still routinely going to IV. And then reevaluating these kids and kind of seeing how often are they needing suctioning, how are they responding to our interventions, as we sort of decide what their disposition is going to be.
Here's just a brief picture of lots of different ways to suction. One of the most popular ones on the right-hand side is the nose Frida, but also lots and lots of more over-the-counter options that are electronic that I find that families are using.
We've had good luck with being able to provide families with our nose Frida equivalent, basically a generic of that when they leave the ED if they don't have one, which at least feels a little bit better than just sending them home with a bulb syringe, because I feel like families in general have more success with being able to clear the mucus from infants with that. From our bronchiolitis guidelines, this lists our discharge criteria, which basically means that their work of breathing has to be very mild. They have to be oxygenating well on room air. It's interesting, families and even some of our healthcare teams get nervous when our kids are in the low 90s, and sort of just using this opportunity to remind them and reassure all of us that as long as the kids are above 90 while they're awake and above 88 while they're asleep, that we feel like they're safe for home. Making sure that the families know how to suction, no apnea in the kiddos, making sure that they're maintaining hydration. And then we have some specific caregiver teaching, including a handout that we sort of went through and built as part of that same working group that did the respiratory assessment classification, in terms of sort of reminding families about what they can do at home, what to expect to see, and then when to come back. For our kids who aren't well enough to go home, and especially, like I said, those kids with moderate to severe work of breathing. So we don't necessarily do it just for tachypnea, but if their respiratory distress is moderate to severe, then we'll often initiate high flow nasal cannula. So again, it's warmed and humidified and at that increased rate. And the evidence it's been hard to study, but it looks like it's not been helpful routinely for every kid who needs supplemental oxygen, but as sort of a rescue therapy or escalation of respiratory support for kids who are having increased work of breathing. And we have a protocol that we've initiated here several years now at UC Davis that has standardized at least our sort of initial treatment with the high flow, starting with rates at 2 liters per kilo per minute, and then we typically max at 20 liters per minute, and then initiating our FiO2 at 50% and then titrating that as well. And then the other thing that's been really helpful is trying to put a little bit more specifics on which kids can PO and what parameters will allow them to PO while they're on their high flow nasal cannula. So having a sort of a reasonable respiratory rate, and then making sure that their work of breathing is no longer severe and that they're not on more than 2 liters per kilo. So in that group, we are allowing them to at least trial PO and then see if they're able to hydrate that way. And if either they can't or if they are falling outside of these parameters, then offering other PO, either NG or IV. Obviously, the kids who are on high flow nasal cannula will be admitted to the hospital. A number of them can be admitted to our pediatric ward depending on sort of how they're responding. So if their work of breathing is mild or moderate, and they are, then they can be on our pediatric ward, even if they're on high flow. For kids who are hypoxemic, obviously those are not kids we're sending home. And then thick secretions that families aren't able to suction at home, I feel like is another reason, or suctioning that's just so frequent that it's not reasonable to expect families to be able to do that at home is another reason that we would admit them. And then I think the last bullet point on this slide is helpful for me, sort of expected progression in clinical course to meet this criteria. I feel like we have a lot of discussions on especially our very young infants who are diagnosed with RSV bronchiolitis or bronchiolitis from any virus, and sort of, they're early in their course, they're looking pretty good, but not great, and sort of basing our disposition on the family comfort level and on the presence of any other risk factors for deciding who can potentially go home and who would benefit from watching in the hospital to just make sure that things aren't sort of going to progress quickly to a problem state. And then thinking of kids who would need to go into an ICU level of care, we have mainly been focusing on sort of our respiratory efforts. So kids who are not improving, so they're still having severe work of breathing despite high flow nasal cannula. And that's when we'll think about other methods of positive pressure, non-invasive ventilation like CPAP next. If they're needing high FiO2, if their mental status is not improving when we give respiratory interventions, or if they're having apnea that's requiring significant intervention, as well as if they're having suctioning that is sort of beyond what our ward level nursing care can do, then those are kids that will go to the ICU. Kids that fall out of our high flow nasal cannula pathway are also those who are on it for something other than viral bronchiolitis. So kids who are on it for lobar pneumonia, or kids who have other health issues, we want to think about that. So comorbid conditions that you can see listed here would fall out of our high flow nasal cannula pathway. So they would still be admitted, but often those kids would go to the ICU, anticipating that they might have poorer outcomes than some of our other kids.
So I was just going to summarize this, that we do try to address tobacco smoke exposure. This gives some resources and suggestions on doing that. But just given that it's a risk factor in terms of frequency of bronchiolitis and severity of disease.